Thank you so much. Thank you so much for joining. And to those of you who will watch later on YouTube, hopefully you'll learn something from this. So as you can see, I had actually put this as our basic ECG 10 because we haven't covered that many. But over the last 2 to 3 months, I've just realized that a lot of people, once they see an ECG that has a lot of changes to it, they sort of just shut down. And even people who I've taught or people who have worked in the field for a long time tend to shut down for the simple reason that it looks complicated. So because it looks complicated, it looks like something I can't manage. So at any point during the discussion, if you need any questions to be answered, please just put it up on the chat or just discuss with me. Or, you can put on your audio, put up your hand, but I think it's easier through the chat for everybody. Okay. All right. So let's get started then, and let's look at this horrifying ECG that we've got over here. So we've got a 50-year-old male. Let's look at that first with indigestion and nausea. So the first thing that we realize, we've got an elderly man, even though it just says indigestion, but indigestion in an elderly person won't necessarily lead you to an ECG. I would suspect that more, unless it's a protocol in your department and you have the capability to do an ECG for every patient, what would actually lead you to do an ECG on this patient is this odd bradycardia mixed with the tachycardia that you would probably see on your 3-lead ECG and things like that, where you would see a similar pattern to this. And then that would lead you to say, okay, let's have a look at a full ECG. Now you put on all your leads, and this comes out and you nearly faint. Now, we're going to discuss this ECG, but I'm going to discuss it in a slightly different way so that you will understand better the point that I'm trying to get at. And the point that I'm going to try and put across to you today is that when things look complicated, the best thing to do is to try and break them down into pieces that you can understand. And if you can understand those small pieces, then it's easier to put the whole picture together. Now, of course, when you look at this looks scary. You want to immediately get somebody involved. You want to immediately, call somebody or get a senior involved. What I would suggest to you is that if you get such an ECG, and we're going to do another one next week, is first take about 5 minutes and have a look at the ECG. And I'll show you a method of looking at these busy ECGs so that you can actually break them down yourself. Okay, so let's just go to one more and then I'll come back to this. So what I like to do and what I used to like to do initially when I had started, when I first started really having to learn ECGs was look at this particular thing, this particular set of circumstances. Now, the first thing is don't panic. Your patient is there, your patient is not dying. So you don't have to rush to make a decision. Give yourself 5 minutes to think about it. Break it down into simpler pieces. So for example, you may decide, okay, I'm going to look at the axis, the rhythm, the rate, and each of the regions. But that already looks terrifying because you can see something is wrong, but you just don't know right now what that is. So what I would suggest is pick out the things that you do understand. And then look at things that you don't understand or haven't seen before. And then you try and make an assessment of what it could be. So you take what you understand, things that look familiar, and you put them in a box. You just put them away somewhere. And you first make a decision based on what you can see, and then you take out the things that you don't know from that assessment. And then you go and look at the things that you may not have seen before, which I know doesn't make much sense now, but then I'll explain to you how we'll go through it, right? So you try and make an educated assessment of the things that you don't know based on the knowledge that you have, and then you decide on your next action. So let's look at this ECG. And the first thing, and I'm sure those of you who are participating live today will agree, the one thing that's throwing or that would make you feel extremely worried is all of these. You can see them right throughout the whole ECG. You've got these wide QRS complexes that are just popping up out of nowhere. They're just everywhere. It doesn't matter which part of the ECG you look at, but these are the ones that are throwing you off. It's going to make it difficult for you to look at your rhythm. It's going to make it difficult for you to decide what's really going on with it. Now, like I say, let's first look at the things that we do know. So let's just discount. Let's take one lead, for example. So let's take lead 3. All right, let's just take this little lead over here, just what we can see just there. And let's take out what we already know is problematic. So this is something that is already triggering my brain, to use a modern phrase. Okay, so that's triggering my brain. And let's look at what we can see now. So now what we have left, once we've just removed that, we're not worrying about these. We're going to come back to these in a little while. I'm going to look at this in a little while. Right now, I just want to look at what I do know. So I've taken these out of the equation. What we see now is that, okay, I can see my little P wave there. Let me just change the color, just so that we can change it. So I can see my little P wave there. I can see my QRS complex. And to some extent, I can see my T wave as well. That's going on over there. All right. So what I'm doing is, once I remove these from my thinking, it might become easier for me to actually pick out what's going on. Now, this is a difficult thing to visualize. So what I've actually done is that I've done it for us on this presentation so that we can actually go through it. And you guys are welcome to try and answer if you can, but I know these are difficult ones, so I'm not going to stress you out if you don't know the answer, but if you can, try and put it on the chat or try and answer. So I've tried my best to try and take the exact same ECG that we saw, but I've taken out all of those weird and wonderful looking QRS complexes that we had seen. Right now, I know it's not a work of art, but it's the closest I could get. So I know things are not 100% aligned, but I hope you understand what I was trying to get at, right? So in other words, we're trying to imagine this ECG without the things that we don't understand, which for most of us would be those large, wide QRS complexes that are just popping up out of nowhere and what make everything seem scary. So this is what is left over once we do that. So now let's analyze our ECG based just on what we know already. And you can see once you start looking at this, it doesn't look as scary now. We're going to come back. We're going to look at the scary part, and what's making it look busy and what's making it look difficult. But let's have a look at what we already know. So let's go in order. Let's have a look at our axis. So here, if we look now, we can see lead 1 and lead AVF. And we can see that they're both pointing upwards, which implies that we have a normal axis. So that's a good start. We know it's not a normal ECG, but at least we can say we have a normal electrical axis. So that's good. Let's go to our rhythm strip. So the first thing that we can look at is our P waves, which we see here. And we see our P waves are generally the same, and they're generally quite regular, all right? Our QRS complexes in this case, just in this case, we're not talking about the rest of it, but just in this case, we can see that they are narrow. These particular ones are narrow. So that means these are the ones that are being stimulated by the SA node to cause the AV node to contract. And they're relatively regular, you know? So in other words, on our patient, whenever the atrium functions, the ventricle is getting the message, okay? I hope you'll understand that. I hope you get what I'm saying at the moment. So we've got this relatively good sinus rhythm besides all of those weird QRS complexes that we had seen earlier. Do we have a normal PR interval? It's slightly lengthened, but not by much. This is a very borderline one. So we'd say it's within normal. You know, it's supposed to be between 2 and 4. It's going just about like 4.1, 4.2. So it's borderline, but it is nevertheless within normal. And like I said, our QRS complexes are narrow and relatively regular. Now let's look at the rate. So let's pick one here. So we've got 1, 2, 3, 4, 5, 6. 300 divided by 6 is 50. So we've got a bradycardia. That's the first thing that we note. So when the atrium is functioning, when the P wave is present and stimulating the ventricle, we are getting a bradycardia. So it's only doing it 50 times per minute. So something is going on. Something is giving us a bradycardia. So let's have a look at the next part. And let's just revise what we found already. So we found we've got a normal axis, we've got a sinus rhythm, but that sinus rhythm is a bradycardia. Okay. Now let's look at each of the zones. So if we look at zone 2, sorry, the inferior zone, not zone 2, sorry. I was filling in a lot of forms today that had stem next, so I wrote zone 2 a few times. My apologies for that. So if we look at lead 2, lead 3, and lead AVF, can you notice the ST elevations that are present there? Okay. I hope everybody can see that. So these ST elevations start to make us think of ischemia. Now, of course, we're going to go through the rest of it, but let's just start there. So leads 2, 3, and AVF are pointing towards an inferior infarct. And an inferior infarct is often associated with abdominal discomfort, or as is described here, indigestion. So this could fit, okay. And the one thing we notice is that the ST elevation in lead 3 is higher than the elevation in lead 2. Not by much, but it definitely is. So this is generally regarded as a right-sided MI, or we say that there's a good chance that we've got a right-sided MI. And the reason why we say that, I just want to draw it out here, is because if you remember, sorry, I'm going to do the best that I can, with the stick figure over here. So if you remember, if we have a normal human being who looks nothing like this, but just so that you understand what I'm getting at, and their heart is sitting, let's say, more or less there, all right, we have leads 2, 3, and AVF that come out 2, AVF, 2, 3, and AVF. All right. Sorry, that was supposed to be a straight line. So let's just put this here. So that's lead 2, right? That's lead 3. All right. So I just wanted to show you so you understand why we say that. Okay. So lead 3 is more towards the right-hand side of the body. So when you start seeing the ST elevations are more towards lead 3 as compared to lead 2, it tells you that the right side of the heart is likely affected as well. So it's not just the inferior portion, which they all are seeing as having an infarct, but the right-hand side is actually seeing more of an infarct. So that's why when the ST segment is higher in lead 3 compared to lead 2, we say that there's an inferior infarct, but with right-sided extension. Okay, I hope that makes sense so far. Now let's look at lead 1 and lead AVL, and here we can see ST depressions. And if you remember from our previous, I should have left those drawings up, but anyway, if you remember from our previous discussions, lead 1 and lead AVL are on the opposite side of the body. Let me just do it again. I think it will serve us better, just so that we can. I'll try and draw a better stick figure this time, but please don't laugh at my drawings. I know they are terrible. Let's just get these here, just so that we can have a look at our limb leads and see what we can figure out from there. Okay. All right. So let's just put the leads. I'm not going to put the heart. So we've got leads 2, AVF is on the chat. Okay, no problem. So leads 2, 3, AVF. Then we have lead 1 and lead AVL that's here. And then we have lead AVR that's going out to that side. All right. So these are our 6 limb leads. All right. So as you can see, leads 2, 3, and AVF are at the bottom, and leads 1 and AVL are more or less on the opposite side of the heart. So we do expect them to have some sort of an ST depression. So we can see we're already building up evidence that shows that we have an inferior infarct. Now, AVR, it depends on the extension of the right-hand side infarct, but in this case, it hasn't really caused much of an effect towards AVR, because AVR is really looking at the top right-hand corner of the heart, which is not commonly affected, but can be as well. All right. Now, let's look at our chest leads. So we've got V1 and V2. And if we were to draw our chest, let's just draw our chest over here. Right? So this is a cross section of our chest. And then let's put our leads in there just so that we can see. So we've got leads 1, lead 2. I'm just indicating them like this just so that you know. Lead 3, lead 4, lead 5 coming in from this side more or less, and lead 6. All right. So these are the points of view that they are looking at the heart from. All right. So it's going to take me quite some time, but anyway, all right, let's just put it like that so that you understand. All right. So they're looking at the heart from this point of view. All right. Let's put our heart in there. A nice pink heart. All right. So we've got a nice pink heart that is divided into our atria, right? Right atrium, left atrium, right ventricle, left ventricle. All right. And remember, the V1 and V2 actually look at the septum. They're called the septal leads. V3 and V4, the anterior part, and V5 and V6, the lateral part, right? So when we look at V1 and V2 now, what we see is that we have an ST depression. Okay, so they're looking at the septum and they're seeing that they are actually they have ST depressions. So when you see that on V1 and V2, because they're looking at the opposites, let's say the posterior part of the heart is here, they're looking at it from the opposite end. There's always a possibility that this could not just be an inferior and right-hand side, this could also be a posterior infarct as well. Not necessarily, but there is a chance. Okay, we're not going to get into all of that right now, but just to explain what's going on. And then we see further that if we go to V3 and V4, we see again anterior wall in ST depressions. So this also fits in with, opposite to our inferior lead. So it's backing up our claim of an inferior infarct. And then if we look at V5 and V6, we can also see ST depressions. Now, ST depressions in V5 and V6, along with ST depressions in V1 and V2, are often associated with posterior infarcts. Okay, so what we've done is that we've taken the things that we know. So this is what we know. We've learned this. And by removing what we don't know, it suddenly becomes a much more simple ECG to look at. So we know already that we have a patient who's got signs of an acute infarction. It's an inferior infarction. It may be going to the right-hand side. It may even be going posteriorly. We have ST elevations. We have ST depressions. So that confirms that it's an ST elevated myocardial infarction. So you know that you've got to start already. Now, whatever else is happening in the ECG, great, that's there. But we've also got a bradycardia and we've got this infarct. So this means we need to start treating this patient. The reason for the bradycardia is the infarction. The patient has damage to the conduction tissue as well as to the muscle. So this is why the patient is in bradycardia. So depending on the protocol at your hospital, you'd get them ready for thrombolysis, or you'd get them ready for PCI, which is coronary insufflation and stenting and things like that. So we've already figured out what's wrong with the patient just based on what we know from our previous experience, without even worrying about the parts that we don't know about. I hope that makes sense just before I go on to the next part. So those of you who are live now at the moment, if you can just let me know in the chat if it makes sense, what I've tried to teach you, that if you can in your mind, or sometimes even physically on the ECG, you can make a second printout and scratch out all the things that you don't know, or the things that look odd or look abnormal, or things that you're not really quite sure what they are. And often when you do that, you find that you're left with something that makes a bit more sense to you and can even lead to a diagnosis. Because if we look at the original ECG that we had, now all of a sudden you realize, okay, this is just an infarct. There are other things that are going on. But once we look at just the things that look normal, or the things that we understand, it suddenly becomes a lot clearer as to what the diagnosis may be. So it still looks scary when you look at it like this, but all that we've done so far, and we're still going to look at the scary parts. I'm just saying, we remove the scary part. So it's kind of like hiding behind the pillow when you're watching a scary movie. So you're going to watch the scary parts now, but at least you know what's going on in the story based on the times you weren't hiding behind the pillow of the scary movie. Okay, so I hope that makes sense. I hope you understand what I'm saying. So when you're dealing with a busy, difficult looking ECG, thanks. Okay. At least it's making sense. So when you're dealing with a difficult, busy ECG that has a lot of changes and a lot of things going on, it's best to simplify, remove the things that you don't understand. And like I say, listen, if you're working in a hospital environment, they can afford a second printout or a third printout. It's fine. You can physically remove the things that you don't know on a spare printout. Or if you want to just place your finger, do something, or even on a single part of it on the second printout, just remove pieces of it and try and analyze what you do see. Because we've already got the diagnosis. We've got an inferior infarction with a bradycardia and a possible right and posterior extension. So this patient needs urgent management because they're in a bradycardia, and chances are they're going to go into more of a bradycardia because of that infarction. Now let's have a look at the scary part. So this is the scary part, and I've taken it just from lead 2 for 2 reasons. Number one, it took a lot of time to create this ECG, and I don't really feel like doing it for the whole ECG again. And number 2, it's easier just to look at it on a single line as compared to a lot of as compared to looking at it on a lot of lines as well. So let's look at the scary thing that was scaring us. So what do we notice about these things? Number one, you'll notice that preceding each of these scary QRS complexes, we don't see a P wave. That's the first thing. So they're not being stimulated by the atrium. Number two, we notice that they are quite wide. So when you have wide QRS complexes, they are generally coming from the ventricle, right? The other thing that we notice is that sometimes, well, they're not regular at all. You can see sometimes they come together, sometimes they come separately and things like that. And if we look at them, they're also coming at a rate of 1, 2, 3, 4, 5, 6, at around 50 beats per minute. Although that's a bit, off-putting at first, but anyway, we'll get into it later. I'll talk about the ventricular rate. But we can see that they're also coming in at about 50 beats per minute. So you've got 50 beats per minute coming from the atrium, and you've got 50 beats per minute coming from the ventricle. And you'll notice that it tends to precede or follow a normal one, all right? So even if you're not sure of the answer, what do you think the heart is trying to do by producing these? Because the ventricle is basically beating on its own in a patient who's got an infarct and who's got muscular damage. He's probably got lower BPs now, and he's starting to become bradycardic. Now, if you're not sure of the answer, that's fine, because you've already got enough to be able to call somebody and tell them, this is what I've got, but there are parts of the ECG I don't understand. But by taking a few extra minutes and looking at this, you realize that you are looking at extra ventricular beats. And so these are extra. These are not part of the normal function of the heart. So there's a few things that you could call these. You could call this an ectopic beat, or you could call this a premature ventricular contraction because it's the heart beating on its own, or it's an escape beat. There's a few names that can be used for it. But essentially what's happening over here is that the heart has realized, listen, I've gone into a bradycardia just from my atrium. My SA node is not pumping, is not giving me enough stimulation to keep myself going. So I've got to put in extra beats, all right, or ectopic beats, or rescue beats, or premature ventricular contraction, whatever you want to call them, in order for me to keep up my BPs, in order for me to keep up the amount of volume that I'm pushing through. So that is what the heart is doing. Now, the question is, let's go back. So now when we look at this, we realize, okay, we've got infarct, escape beat, infarct, escape beat, the heart trying to rescue itself. Even if you look on the rhythm strip, we've got an abnormal beat, normal beat, abnormal beat, normal beat. So the heart is trying to rescue itself. And what happens is by doing that, if you now look at the ventricular rate. So not the atrial rate is 50. The atrium is only beating 50 times per minute. But if you look at the ventricles, they're going at about 1, 2, 3, at about 100 beats per minute, sometimes 150. And there we go again. Here it comes closer to 70. Here it comes again closer to 150. So even though it's relatively irregular, what the heart is doing is that when it realizes that there's a volume problem and a blood pressure problem, or let's just say it actually has more to do with Starling's law, but I don't want to get too intricate with it now. So what happens is that the heart then is trying to rescue itself, okay, and prevent further infarction. But the one thing that we've got to think about now, what do you think would happen if the heart was unable to keep this up? In other words, if the infarction gets worse? Because you already know the diagnosis, you already know what's going to happen, you've already started your treatment. Now we're actually going to a point where we're trying to say, okay, now I've got to prepare myself for what could go wrong. So what do you think could go wrong in this patient? Any ideas? I'll give you a minute to think about it. So just so that you now sitting in your emergency department can say, okay, what do I need to have ready? Because there's a possibility that some things may happen. It's okay if nobody knows the answer. I'm not stressing about that. I'm just giving you a minute to think about it, okay? And then I'll give you the answer if nobody answers. Don't stress. All right. So the worst thing that can happen now is that the infarction spreads while we're waiting to do everything. And as the infarction spreads, it tends to affect more of the conduction system. And as it affects more of the conduction system and more of the muscle, we may find that the heart is unable to produce these PVCs or ectopic beats. And then what happens is that we go into more and more and more of a bradycardia. Because remember, even though we do have a sinus bradycardia, these ectopic beats are actually helping the patient to stay alive. So should they disappear, you've now got a patient that's going into bradycardia. And it could be a wide complex, narrow complex. Chances are it would probably be narrow complex, but it could be wide complex. So that means sitting in my emergency department, I know I've got to have everything ready in case this patient does go into a bradycardia, which we've discussed before. So I would have my adrenaline ready, my atropine ready. I would have my pads ready in case I need to pace this patient. And that's what I need to worry about. Now, of course, in this case, we would have taken our enzymes, we would have done our bloods, our ABGs, our baselines, and we would have already called for senior help. And when I say senior help, I mean, we would have called for cardiology and we would have called for medicine, depending on the level of hospital that you're working in. Or even if you're working private in a general practitioner's room, family medicine clinic, whatever it may be, these are the types of patients that you know you need to now get sorted out. So I just want to know if everybody understands what I've tried to put across over here and if it makes sense what we're talking about. Those of you who are live can just let me know via the chat if it makes sense. So we've realized that we can remove the parts that we don't understand. We can then try and analyze the parts that we do understand, and then have a look again at the parts that we don't understand and try and understand what they could be. Now, you may not have seen anything like this in your life, but just using a few minutes of thought and saying, okay, I've got wide QRS complexes, you could even say, you know what, I've got intermittent ventricular beats. That's not the important part. The important part is that you diagnose the infarction. So somebody is going to come and take over this patient, get them into ICU, possibly get them thrombolized on PCI. So I hope you understand that that's the most important part, is to actually make some sort of a diagnosis on a busy ECG, even if you can't make a complete diagnosis. The problem with us is that when we see this, we panic and we shut down. Because we can't make out a pattern immediately that we understand, a lot of us tend to just shut down and say, I will never understand this ECG. So I hope you guys understand what I'm trying to put across, that you need to take what you understand, put it on one side, take what you understand, put it on another side, and then analyze. Okay, thanks. I appreciate that. Okay, so if you guys understand so far, then that's great. And if there's anything that you haven't understood so far, please, by all means, put it on the chat, and then we can take it further. All right, so this is just one example of a busy ECG. All right, so just before we go through the answer, we're going to practice one of these next week, Monday as well. And after the presentation today, and after I've uploaded it a bit later to YouTube, I'm actually going to put the next ECG that we're going to have a look at, so that you've got, it's going to be about 4 to 5 days to actually look at that new ECG and try and practice on that and see what's going on. And then we go back to doing different types of patterns so that it becomes much easier. So as I said, we had a sinus bradycardia, a ventricular rate, they've put it here of 105, frequent premature ventricular contractions, and an acute inferior posterior MI. All right. So as we had mentioned, the P waves appear at a rate of about 48 to 50. It's uncertain if additional P waves are obscured by these PVCs that we had seen. It's difficult to say. And they appear in a pattern of bigeminy. Don't stress about that now. Okay, I don't want to get too much into that. Intrinsic beats. So that means those that were normal. So that's the intrinsic beat. Has an ST elevation in the inferior leads, consistent with an acute inferior MI. And in the right precordial leads, there's also evidence of an acute posterior MI, which I had mentioned. And these are the things. So you get ST segment depression, tall R waves, and upright T waves, which is one of those things that you see, but there are other things also, right? And then we don't stress too much about all of that, although in this case, the patient went for PCI and had an occluded right coronary artery. And remember what I told you guys before, for a patient with a suspected right-sided MI or anything involving the right-hand side, even the posterior, we don't give them TNT, all right, for reasons that I explained previously. So we've come to the end of it. If you have any questions, now is the time to ask. This is 100% correct, even though it's a joke. You've got the humpy bit, the lumpy bit, and the jiggly bit. The red flags, if you have lots of jiggly bits, which we saw in ours, a lumpy bit on the jiggly bit, which we didn't see in this one, we'll see in another one, big tall lumps, which I see there. And if there's no humps or jiggles, your patient is dead. And squiggly stuff you have no idea about, but the patient looks bad. So it's a joke, but it actually encompasses a lot of what we do. The humpy bit, jiggly bit, and lumpy bit should be normal. If there's too many or too few, or they're too close together or too far apart, that's when you've got a problem. So I hope you guys understood. I hope it makes sense. And like I say, we're going to practice with another one come this following Monday. We're going to go through that, and we're going to learn, hopefully, over the next few weeks and months, and not just do advanced and these very busy ECGs, but at least to give you one more chance to practice. And in a few weeks, we'll do another one again. So I hope that's okay for everybody. If anybody has any questions, now is the time. But if everybody's satisfied, then we'll end up here. So you can just let me know on the chat, and then we can take it further from there. But I hope it made sense. I hope the presentation was okay. And please feel free now to go back, have a look at the ECG as it was posted on the group, and try and do it for yourself as well, or go through the video, pause it at the relevant parts, pause it at the parts where I blanked out, try and figure out, correlate your thinking with what I was saying, so that hopefully it makes sense. And at the end of the day, you can easily save a patient like this, because even though you don't understand the scary bits, the non-scary bits, the intrinsic bits, were so easy to understand once we just remove the parts that were difficult. And that's what we'll do for the next one as well. And hopefully it will make sense. So I see there's no questions coming through. So I just want to thank everybody. And we'll leave it at that. And okay. See. Okay, no problem. No, thank you, everybody. I really appreciate the attendance, and I hope you learned something. And let me just stop there. And thank you very much. And we hope to see you all next time. Okay, keep well. Bye.